Hi, and welcome to this video lecture. My name is Marco Annoni. I am a bioethicist with an expertise in placebo studies, and today I have the pleasure of introducing you to an exploration of a fascinating topic, that is to say the ethics of deceptive research, and specifically for placebo studies. So the lecture of today is organized in 9 very brief and synthetic parts. In the first one, we will be looking at the definition of deception. Then we will move to explore a potential rationale for justifying, from a scientific point of view, the use of deception in scientific research. And then we will explore the 3 main objections or rationales to oppose the use of deception in scientific context. One that has to do with informed consent, and the other 2 that have to do with the respect of participants' autonomy and trust, respectively. Then we will see, although very briefly, the 2 main mitigation strategies that researchers ought to deploy whenever they choose to conduct a deceptive study, namely debriefing and the option of data withdrawal, and how they should report the results of deceptive studies in published research. So whenever they publish the data, the results of their deceptive experiments. Finally, we will explore very briefly, again, the relationship between informed consent and a possible alternative to deception, that is to say, a paradigm based on the concept of authorized deception or authorized omission. And lastly, we will be looking at how what we have been saying throughout this lecture applies in the case of persons and research participants who are non-autonomous for different reasons. And finally, of course, we will draw the conclusions. Most of what I will be saying, it's based in this article that has been published last year, and you will find it in the readings together with 2 other articles that I think are very useful if you want to explore what we will be analyzed today. Before we begin with the main content, a bonus take-home message. Basically, whenever we approach the topic of the ethics of using placebos or harnessing placebo and nocebo effects in clinical and research context, today we might be under the impression that they are, so to say, their own set of moral and ethical problems. So that if we have problems, ethical issues relating to the use of placebos and placebo effects, they constitute somehow a separate issue from other more general ethical problems. But this is not really the case. So a bonus take-home message, it's simply that whenever we approach the ethics of using placebos and placebo effects in clinical and research context, in 95 of the cases, perhaps even more, what we are dealing with is a simple specification of a broader moral issue. And that broader moral issue is the ethics of telling the truth or the ethics of deception, if you look at that from a different perspective, as it applies to medicine in general or science in general, so to clinical context and scientific context. So, and this applies also to what we will be looking at in this video lecture, basically a simple specification of a broader moral issue, that is to say the ethics of truth-telling in medicine and science. So that being said, let's begin with the introduction and let's look at the definition of deception. Now, as with everything touched by philosophical reflections, you will notice that if you look at the literature online or textbooks, you will find a plethora of different theories about what is deception, how can we conceptualize it, so on and so forth. But for the purpose of today's lecture, we will be looking at perhaps the most popular definition of deception, according to which deception entails the intentional distortion or omission of information in order to cause someone to entertain a false belief. Now, this definition is very useful and has 2 main points that we need to address and explore. The first is the word intentional. according to this definition, in order to deceive someone, we must necessarily have the intent to deceive that person. So it's an intentional behavior, it's an intentional conduct. And that's very important. So we cannot deceive someone according to this definition if we do not mean to deceive that person in the first place. So deception is always intentional. Secondly, as you will see, deception can also be performed through omissions. So we can, for example, leave out details from an explanation in order to cause someone to entertain a false belief. And under this definition, this also counts as an instance of deception. So we can deceive with acts and we can deceive with omissions. A simple example from a standard case in clinical practice. Look at this quote. There is a clinician telling a patient, I am prescribing you a pill which research suggests can be of benefit to you. In your circumstances, I have reason to believe that it will work with a minimum of side effects. Now, the pill, it's a placebo. But under this way of portraying the pill, it's very legitimate that the patient may be led to think that the pill is not a placebo. It's just an active medication, just like any other pill that is given in clinical context. Now, if in this case, the physician is telling this kind of story, this kind of description with the intent of causing the patients to believe that the pill taken is not a placebo, but an active medication, this will count as an instance of deception, even though there is no open lie, so to say, in these statements. That's important because as we will be looking at the way in which we can describe placebo effects and placebos in clinical trials, it's important to remember that also omission do count as an instance of deception. So now let's pass and look at why deception must be or should be used sometimes in scientific context. So why is deception needed in science? Well, as you well know, before enrolling in research, all competent adult participants must provide their valid informed consent. And in order to do so, they must be truthfully and adequately informed about the main features of the study in which they will partake. So typically, this information include the true purpose of the study, the methodology, the final results, what kind of interventions will be provided during the study, so on and so forth. Sometimes, however, a transparent disclosure of such information concerning the very nature of the study may conflict with the purpose of obtaining valid scientific knowledge. So, for example, let's imagine that we are organizing a study in order to observe the attitudes of participants with respect to cheating or lying. Well, obviously, if we inform beforehand that this is the true purpose of the study, we run the chance, it's very likely, that the participants will alter their behavior in response to such disclosures. And the same thing applies also in the case of many studies involving placebo phenomena, placebo effects, and nocebo effects. For example, in studies in which we want to observe precisely the role of expectations in pain perceptions, for example. If we tell in advance that that's the true purpose of the study, we might alter the expectations of research participants, thereby invalidating the data that we are collecting through our experimentation. So in general, truthful disclosures for the sake of informed consent may be problematic in experimental studies investigating cognitively mediated phenomena such as human perception, sensation, attitudes, behaviors, or interpretations and beliefs. And this is obviously the case also of placebo studies. So that's why sometimes deception might be needed in this context. And in fact, when the provision of a standard disclosure for informed consent is incompatible with the scientific aim of the study, a deceptive design might be considered by the researchers. And obviously, in a deceptive design, participants are deliberately misled or not informed about salient aspects of the study. For example, the true purpose of the study or the true role of some of the experimenters, for example. So that kind of strategic deceptions or omissions are meant to preserve the internal validity of the study by manipulating the information available to the participants. And for certain investigations in psychology or neurosciences or in placebo studies, strategic deception may be the only option to obtain scientifically valid results under certain circumstances. So you see, deception sometimes is needed really to obtain valid results. As you can see here, there are a couple of examples that we can cite, but given the fact that this lecture is supposed to be very brief, I will only refer to one example, that is to say the use of a balanced placebo design. So let's suppose, for example, that we want to study the role of placebo effects and expectations with respect to certain conditions. Let's say the study of caffeine, for example. So we want to know whether the effects of caffeines or caffeinated drinks are due to caffeine or to the expectations of study participants, or maybe to both, and in which percentage. How can we study those kind of phenomena? Well, if we look at the literature, of course, there is one particular study design, which is a deceptive one, that can be very useful to study those kind of phenomena. It's the balanced placebo design. So it's a design according to which we divide the study participants in two main groups. One group receive an intervention, so in this case, for example, a caffeinated drink, and the other group instead receive a placebo, so a decaffeinated drink. And that's really the genius idea beneath this kind of design, we further divide each group into further groups. One in which we tell them truthfully what they receive, and the other in which they are instead misled or deceived about what they are getting. So we end up with basically four different groups. A group that get the placebo and is told that that's just the placebo. So they have presumably not the effect of the intervention nor the effects of the expectation. Then we have a second group in which they get the active treatment, so the caffeinated drink, but they are told that they are getting a placebo. So in this group, presumably, we will be measured at the end of the study only the treatment effect. Then we have a third group in which they get the placebo, but they told that that's the active treatment, so that's the caffeinated drink. And that's the group in which we measure the placebo effects, in this case, the effects of the expectations. And finally, we have the fourth group in which they get the active treatment and they also are told that that's truthfully the active treatment. And so presumably we will observe the combined effect of the treatment effect, caffeine, and of expectation in this group. So as you can see, this is a very elegant trial design that is very useful to disentangle the relative effects of expectations and of the treatment effect, in this case, caffeine. But of course, it's a deceptive design. So it can be scientifically useful, but also, as we shall see now, it's ethically problematic, just like any other scientific study that use a deceptive design. So why is deception ethically problematic? Well, obviously, the first reason is that it infringes on informed consent. So it entails that research subjects are not fully or truthfully informed about salient aspects of the study in which they participate. Hence, deception, as I said, is incompatible with the standard process of obtaining informed consent. So it's important to say this because it means that if you want to run a deceptive trial like a balanced placebo design, you have first to obtain permission to alter or waive the standard requirement of informed consent from an ethics committee or an institutional review board. So you have to apply and to say that in this specific case, you have reasons to alter or waive the standard process for obtaining an informed consent. Now, there are 4 important conditions before you can actually do that. So first, you should be able to argue that the study is scientifically sound. So deception is ethically problematic, but it is unjustifiable, the use of deceptive designs, if there is no scientific rationale backing up the necessary resorting to deception. Secondly, the study should involve no more than minimal risks for participants. So, for example, in the previous example of the caffeinated drinks, that's just not even a minimal risks for participants. For in the worst case scenario, they get decaffeinated drinks. You should be able to argue that the study cannot be performed without deception, because otherwise, since deception is ethically problematic, you should opt instead for truthful disclosure. And whenever possible, and that's a key condition, the subjects will be appropriately informed at the end of the study. If these conditions are met, a study may be ethically approved, even though it is deceptive. So just focus on these 4 conditions, and we will return on the 4th one. Now let's look at 2 other ethical rationales that are crucial to understand how to plan in advance some mitigation strategies for deceptive studies. So in addition to informed consent, there are these 2 other rationales, one referring to autonomy and the other one referring to trust. So in general, autonomy can be defined as the capacity to decide and act according to a self-chosen plan, free from controlling influence by others. So specifically, at least in biomedical ethics, the general duty of respecting participants' autonomy can be understood as the conjunction of 2 more specific obligations. One is the duty of not infringing on participants' liberty by forcing or coercing them to participate in research. So a typical example of an infringement of participants' liberty is provided by the, of course, experimentations on prisoners of war, for example, in which they are not asked but forced through violence to participate in those kind of inhumane studies. And then the other is the duty of respecting and fostering participants' agency by providing them all the relevant information to make autonomous choices. And of course, as we are dealing with the ethics of deception and manipulation by extension, today we are looking more closely at the second moral obligation composing the general duty of respecting participants' autonomy, namely the duty not to infringe on their agency and of providing them with all the necessary information. The second rationale instead refers to trust. So in science, obviously, trust is essential to ensure that people volunteer for research. And without a minimal threshold of trust, the only option to advance scientific research would be to resort to coercion and force, as I said before. So a clearly unethical way of fostering scientific knowledge. And in part, a trusting attitude toward volunteering in scientific research is based on the belief that the research participants will not be exploited by researchers or exposed to significant risks without their consent. Deceptive studies, however, cast a legitimate doubt about the respect of such fundamental ethical obligations by researchers and scientists. And accordingly, deceptive studies may compromise individual and public trust in science, potentially impairing scientific progress and, as we are seeing today, also public health. For if people fail to trust what is said by clinicians, healthcare professionals, or scientists, then there can be unwanted consequences on all levels of healthcare, including, of course, public health issues. So now we have seen what is deception, why deception sometimes is needed or required in scientific context in order to obtain valid results. And then three main rationales for arguing that basically the use of deception is ethically problematic. The first one concerning informed consent, the second one concerning the respect of patients' autonomy, more specifically, the respect of the duty to foster their agency by providing complete and adequate information during information disclosure, and thirdly, the third one concerning trust. Now we are exploring, instead, we begin to explore the mitigation strategies in case we decide to run a deceptive study. So to cope with the ethical implications of deceptions, researchers should plan and implement in advance mitigating strategies at the end of the study. As we have seen, altering or waiving the requirement of informed consent requires meeting certain conditions, one of which, the last one, mandates that all participants should be debriefed at the end of the study. Typically, the information disclosure of the briefing occur at the completion of the research when participants are informed about the true nature of the study and about the use of deception. So they are informed about what the study was really about, the true role of all those involved in the experiment, and so on and so forth. Usually, the briefing involves a structured disclosure procedure for participants. It may entail a research assistant reading a script or a phone call or a contact via email, so it depends on the study. And I'm sure you will find your own way of providing a good debriefing during the experiment in the MIWI training program and experiments. So why it is important to debrief the research participants? Because by disclosing the use of strategic omission and deception, debriefing ensures that no scientific research is conducted without eventually informing the research subjects. An important point, so it is mostly for preserving trust, as we will see in a minute. But another important point is that debriefing per se does not aim at adding data to the study. So the purpose of implementing a debriefing procedures in studies, in scientific research, it is not for a scientific purpose. It's solely and squarely for an ethical purpose. That is to say, to preserve trust and avoid undue exploitation in scientific research. So debriefing has an eminently ethical role and justification. And then this is a topic that is seldom discussed, but it's really important. And now we will see hopefully why. So debriefing is very useful, but it cannot cancel the infringement of autonomy. Remember that there are different rationales from consent, autonomy, but also trust. Because informing someone about a deception that has already occurred does not provide any actionable way of compensating for the preceding loss of agency. So simply by telling someone that we have deceived him or her, it's not really amending to the loss of agency that we procured through the use of strategic deception in the first place. So for this reason, it has been proposed that in deceptive studies, debriefing should be coupled with the possibility for participants to withdraw their data from the study. The option of data withdrawal allows participants to partially restore, although in a sort of a posteriori ad hoc way, their autonomy by shifting back to them the decision over the use of deceptively obtained data. Furthermore, it also ensures that people do not contribute to studies in which they would have not participated in the first place had they known the truth in advance. So the truth about the true purpose or the inner workings of the study. In case it is anticipated that it will not be feasible to debrief all participants or to offer them data withdrawal options, researchers should provide a convincing rationale for such decisions as part of their application to obtain ethical approval from competent ethics committees and IRBs. So according to what we have seen so far, there are two main mitigation strategies. debriefing and the option of data withdrawal. But in any case, you should plan for them in advance and justify whenever you anticipate that it might not be possible to resort to those two mitigation strategies as you conduct a deceptive study. Now we pass to the third mitigation strategy, so to say about the use of deception, that is to say what we ought to do whenever we publish the results of a deceptive study. So researchers have an ethical duty of truthfully and accurately reporting the methodology of their studies in scientific publications for all kinds of reasons, including the possibility of replication, for example. But in particular, it is important to stress that in reference to deceptive studies, it is highly misleading for research reports to declare that all participants have provided their informed consent. And if you look online, that's an experiment you can do, and you search on PubMed many studies using what we have described as the balanced placebo design, you will see that most of them still nowadays report in the methodology section that all participants provided their informed consent, which is obviously impossible for, as we have seen, the balanced placebo design is by definition a deceptive study, and deception is incompatible with the provision and obtainment of a valid informed consent. So it's highly misleading to report those kind of studies by stating the standard sentence, all participants have provided their informed consent. Instead, to avoid any confusion and possible allegations of research misconduct, researchers reporting the result of deceptive studies in scientific publications should include an explicit description of the following points: how and why the research included elements of deception, how the consent process deviated from the standard elements of informed consent, whether these alterations received the approval of an ethics committee or IRB, and the procedure implemented for debriefing, and whether participants were given the opportunity to withdraw their data. So ideally, this kind of information should be inserted in the methodology section, but for in case, for example, of space limitations, they can and should be provided with the supplementary materials, for example. So we now pass to an alternative that has been proposed that's very viable, that is to say authorized deception. So an alternative to the standard waiving of informed consent for deceptive study, as we have seen, is to use an authorized deception or an authorized deception paradigm. So in such kind of disclosures, the participants are truthfully informed at the very beginning that some statements about the research design of the study might be inaccurate or misleading. So for example, they might receive a disclosure that telling them that we will label all interventions provided in the trials, but not all of them are necessarily truthful, for example. So this is a viable strategy in order to circumvent the ethical hurdles of resorting to deception. But there is also a counter argument for certain studies, for example, certain studies in placebo studies, that this way of informing in advance research participants may somehow still alter their expectations about what they are getting. For example, they may become distrustful about the true nature of the interventions they are receiving. And so there are objections to the fact that by implementing an authorized deception approach, we still obtain data that are equally valid with respect to a similar study that would implement instead a standard deceptive approach. So the jury is out. It also depends on the trial, but this is definitely a viable strategy for other kinds of studies or for certain kinds of studies. And so it's useful to discuss that as well. We should also say that while authorized deception falls short of full informed consent, it at least it provides participants with the opportunity of deciding whether they want to participate in a deceptive study, or at least in a study in which not all informations are truthfully stated at the very beginning. Nonetheless, researchers employing an authorized deception design ought still to receive the ethical approval from an ethics committee or the IRB. They still have to debrief participants at the end of the study, revealing what has not been revealed before. They have to provide the option for data withdrawal and describe the use of authorized deception in the scientific publications reporting the study finding. Finally, let's very briefly look before concluding at a very important and under-discussed topic, that is to say the use of deception in studies with persons that are not fully autonomous. So we are dealing, for example, with cases in which there are persons that suffer from dementia or from other conditions, and so they are mildly or severely cognitively impaired, for example, so this kind of situations. So obviously the point is that non-autonomous persons, or at least persons that are not sufficiently autonomous, cannot provide a valid informed consent in the first place. So somehow in this kind of studies, we split the problem that we have been examining until now into separate cases. For there are the participants who are not fully autonomous, but there are also other persons providing for them a surrogate informed consent. For example, the legal tutor, for example. Now, that's important because in some respects, this provides an ideal situation for researchers, for they can still use deception with the research participants who are not fully autonomous, but they can also provide a truthful informed consent to the surrogate provider of the informed consent, the legal tutor, for example. So in this way, we can somehow have both ends at the same time. So we can have a deceptive study without the ethical difficulties of using deception for the purpose of informed consent. However, we should be very careful in these situations because other considerations related to the general respect of patients' autonomy and to trust still apply with respect to those persons that are not fully autonomous, but that we want to enroll in a deceptive study. And they should be critically evaluated during enrollment and while conducting the study. So what's the important point here? What's the take-home message? Well, the take-home message is that you should, in any case, respect the capacities and the trust of those persons, even if those persons are not legally able to provide a valid informed consent. They might have a relevant degree of autonomy, maybe not up to the threshold for which they could be considered fully autonomous and so able to provide a fully valid and binding informed consent, but still they are autonomous persons to some extent, and we should nonetheless respect that residual autonomy. And also there are considerations of trust. So not just because a person is suffers from certain conditions, we have to disrespect or to use deception as we please with them, because maybe we are impairing their trust about other important issues. And so we have to be really careful in conducting those kind of studies as well. So deception is always ethically problematic, even with persons that are considered not fully autonomous. If you're interested in how you can relate or use paternalistic interventions, basically, in clinical practice, but also paternalistic ways of dealing with people that are not fully autonomous, I can provide you with a text of this chapter that I wrote about patients' protection and paternalism in psychotherapy for the Oxford Handbook of Psychotherapy Ethics. I'll be more than happy to provide you the full text, or at least the preprint if you're interested. So let's go to the summary of today's brief video lecture. So the use of deception in research is sometimes necessary, but always ethically problematic. The main rationales to criticize the use of deceptive placebo studies or deceptive designs related to informed consent, autonomy, trust, and also non-maleficence. Non-maleficence, we have not seen that that much in today's lecture, but basically is related to avoiding the exploitation and possible harms to research participants. And of course, informed consent is a precondition for that. Thirdly, researchers planning a deceptive study should always seek ethical approval and must design appropriate mitigation strategies. And if you cannot put in place appropriate debriefing, data withdrawal options, and explicit reports in published studies, well, you should better have a convincing justification for not doing so. So always be prepared in advance whether you plan or evaluate the possibility of conducting a deceptive study. And with this, I conclude the lectures for today, and I'll be more than happy to reply to any possible doubts or questions that you might have through email or in person during the other session of the program. So thank you very much. And I'll see you in the next lecture or in the next occasion in the MIWI program. Thank you.